It's time for Sambai Speaks.
It is, we're back.
We're back for another episode of Sambai Speaks. We're so excited today to talk about something we haven't really talked about yet. And it's one of the rarer cancers, but it's a killing cancer, and that's pancreatic cancer. So today we have our miracle patient advocate, Kyle Samuels, who's really, he celebrated his cancerversary, his first cancerversary this week. And then our lovely Dr. Fieke Froeling, who is my awesome friend from University of Glasgow and our Sambai partner. So, and she's seeing these patients every day and giving them hope and love and solutions. And so we want to talk about this tough cancer and I think we can learn a lot from Kyle's story, but also how we're sort of approaching the challenges for Sambai. So you guys want to introduce yourselves real quick? Not real quick, however. Kyle, you go.
Oh,
and
hey.
We'll come back to your story.
Absolutely. So my name is Kyle Samuels. I'm the founder and CEO of an executive search firm called Creative Talent Endeavors. And as Ricky said, yesterday was a year to the day, the year anniversary of my cancer diagnosis. It has been a interesting 12 months, to be sure, included with diagnosis and surgery and chemotherapy and diabetes, etc. But very happy to be here, literally and figuratively.
I love it. I love it. We're so glad you're here and healthy.
Yes.
And Dr. Fieke, we love you.
Yeah, thanks, Ricky and Kyle. So I'm Fieke Froeling. I'm a medical oncologist and a physician scientist with an interest in pancreatic cancer. So in the clinic, I treat only pancreatic cancer patients, and then I do the different clinical trials, but also use the clinical observations that we make in the hospital to the research laboratory to see what can we learn from our patients, almost from our patient data, to find better and new treatments. So that's what I spend most of my days on.
So how many days a week are you the doctor in the clinic or versus the researcher in the lab?
Yeah, so on paper, they say it's usually 2 days in the hospital, 3 days at the university in the lab. In reality, it's basically sometimes feels more like 2 full-time jobs, but because you have with Teams and Zooms and emails, you always, even if at the university, you are speaking sometimes with patients. So, but
yeah,
the busy clinical work and the clinics or your MDT or molecular or your tumor boards, how you call it in the US. So all those meetings and activities, they are that's 2 days full-time work. Yeah.
Right. Well, yeah, the patients don't go away when you're in the lab.
That's the thing.
Right. They're always there, right? Yes. Right. Wow. So Kyle, tell us your story.
You caught me mid-protein shake.
That's okay. Protein shake. That's really important.
My story is, one of I always say awareness and advocacy. So May of last year, it was a Friday night, maybe 7:30, 8 o'clock. My wife comes in the bathroom. I'm on the floor. I sweated through my t-shirt and I'm like writhing in pain. I thought it was just indigestion, right? So I was like, oh, let me take some Pepto. We'll be fine. She's like, let's go to the ER. This seems serious. So go to the ER.
So what were your symptoms? You were on the floor. Like, how'd you get on the floor?
Yeah. So my lower.
Give us all the good scoop.
Yeah. So it was my stomach and really my lower back. Your lower back, right above your buttocks or whatever. It was just like this throbbing pain that just like, had me doubled over and sweating and just going crazy, right? And so.
And that was the first time you had the pain? Was that the first time you had the pain?
No. So actually, in February of last year, it happened. It was a little bit. I won't say a little bit. It was more minor, and so it was funny. My wife was traveling for work, so it was just me, and so same thing. The sweating through the shirt, but then it went away fairly quickly. So I was just like, oh, all right, didn't think about it. Right? So then we have the remix in May of last year, and they got to put me in the wheelchair to get me out of the car into the hospital. They thought it was maybe my appendix. It wasn't. And so they're giving me pain medicine, etc. And my wife, because she has a background in medicine, she goes, well, hey, can you do a CT? And again, so like I said, the awareness was number one, her being aware that this was something serious enough to go to the hospital to check out. And then the advocacy, and again, that's just special because she has that knowledge, but to say, okay, well, what about a CT that can give us more information, right? And so they run the CT, they come back and they say, oh, Mr. Samuels, do you have pancreatitis or pancreatitis, right? Pancreatitis. And I go, not that I know. They're like, well, like your pancreas looks inflamed. Okay, great. So this is a Friday night. I'm able to get in to see my doctor the following Monday, and that's when he
They
tells,
sent you home from the ER, from the ER?
like went home around 2 o'clock in the morning. The pain has subsided, etc. And so I'm thinking I have pancreatitis. All right, cool, we can fix it. Well, no big deal. Diet, etc. And so we go to my doctor, and then so she runs a bunch of tests, including the CA 19-9.
What's that? What's
And
that? CA 19-9.
CA 19-9 is a test that looks for and Fieke could probably say it more eloquently than me, but I'd say for layman's terms, it's not 100% definitive necessarily if you have like the healthy range is 0 to 32, but it's one of those indicators that shows that cancer is likely somewhere inside of you, right? And so the normal range is 0 to 32. My score or whatever, my number was 379. So I'm 10x the high part of the range, right? Which again, I see your grimace, but here's the funny thing. When I went to go see some of the doctors, one of the oncologists I saw, he was like, "Oh, you're a piker." He's like, "Usually when I'm operating on people, they're in 4 digits, right? So just think about that, right?" And so even then, and it's funny, I think I think I know my wife kind of knew, uh-oh, but she didn't want to freak me out. And I'm still thinking like, all right, well, we'll see. Because I've never had cancer, doesn't run in my family. I don't smoke, I don't drink. So I'm just like, I wasn't super worried. But then when we go to, I get my endoscopy, and then that's after that when we go, and I could tell that the doctors were not prepared to tell someone they had cancer that day. Because like, sometimes with these tests, like in these apps, you as the patient get like the results before the doctor
Oh,
sometimes, or at
yeah,
least
the
you
my
think that,
chart.
right?
We hate that my
My
chart.
chart, my chart.
My
And
chart.
so
My
I'm
chart
looking
is
at it.
basically a system that tells patients what they have, and often before the doctor talks to you.
Yep.
So that's
And so
something.
I'm rolling.
I don't know if we have that everywhere. I don't know if that's something in
Right,
Scotland either.
Yeah, they changed the rules that you have full access to medical history.
Nice.
All
Yeah.
of that.
Yeah.
And so I'm going to the appointment to get the results, and it comes through in the car, and it's like, not melanoma, but it's like cancer. And I'm just like, okay, this doesn't sound good. And so like when they first come in, they're like, hey, Mr. Samuels, how are you doing? Let's sit down. And then it's like they go to the computer, and then they come back and it's like, hi, Mr. Samuels. You know what I mean? Like it's just like they realize like,
Change the
oh crap,
voice.
right?
Right.
So they give me the news, and went and got pastries afterwards. And it's just like you get this diagnosis and you're thinking about it, and you start looking at what's I'm looking for, survivability rates, et cetera, blah, blah, blah. And so that's when the next step was going to see doctors to see about the course of action, right? And there was
Did they tell you
basically
your stage? Did they tell you your stage at that point?
after we went to go, I think that they first did it when I went to go see the oncologist afterwards. So they kind of explained, they were like, they kind of call it like stage 2.5, right? They're like, it's like a soft thing, but you're definitely not stage 4, but it's a little bit more stage 2 because it kind of like hit another organ or something like that, right? And so options are surgery, then chemo, or chemo, then surgery, right? I mean, if you're taking medical options, I decided I just wanted it out, and then we'll do the chemo. And
Hello.
so that's what I went with. And I'm very lucky too, because Ricky, someone, Dr. Elizabeth Franklin is someone that in my network. And, when I had this diagnosis, there were very few people I could reach out to. So I reached out to her, and she was able to, share her network and connect me with some people with Duke. So long story short, I did not need to go do the Whipple. I had laparoscopic surgery July of last year, went to Duke. I was in the hospital for 5 days, came back home. And again, by the way, I've been an entrepreneur since 2017 is when I started my business. This is the only time since then I've been like, it wouldn't be bad being an employee at a Fortune 500 company, right? Because not
Health
only
insurance.
you go through it, well, the insurance was fine. I'm lucky there, but it's like you think about what do I tell my clients, right? Because think about it. You don't, because you also don't know when you go in for surgery.
You don't
Yes, with
know.
all the MRIs and stuff, but they never, oh, it's in your blood. It could be, there's always a situation they go in there, they go, sew him back up and just let him have the best 6 months he can, you know what I mean, of his life, because it's not, there's nothing we can do, right? And so you don't know what to tell your clients because you don't want them to be like, oh, all right, guess Kyle's not going to be in business, so let's take our business elsewhere. You don't know what to tell your employees because since you don't know, you don't want them, and it's rational to be like, well,
Yeah.
this company is not going to be here. What does that mean for my job? Do I start looking, et cetera? And so what I said is, hey, I'm going in to have some surgery. I'll be out for about a week. I'll keep you updated. Because again, I didn't know. Because if the answer,
Right.
if they went
Right.
inside and said, hey, man, it's not looking good, then guess what? The company is closed. Here's some severance, and I'm going to live my life out. So since I didn't know, I wanted to, have data. And so luckily the surgery was successful. And that's when I was able to tell the team and share with the clients. And I've been very vocal about this, which is interesting because I'm a very introverted person. But the reason why is because, again, it's so insidious. And Ricky, as you asked, the only symptom I had was my lower back hurting. And again, like I always say, you get 40 plus, your lower back hurts. You do not go, oh, it must be cancer, right? You're like,
Right.
oh, I got a pharynx
Pancreatic
in it.
cancer
I
at
got to
that,
stretch.
right?
Exactly,
Right.
exactly. And so, had the surgery, had a few months to get my energy back after that, and then went into chemo. So I had surgery in July, started chemo in September, finished that February 18th of this year. So we're almost 4 months to the day past that, which is crazy. And it's just been, it changes your life for sure. It's made me grateful for certain things that you might think like, you had this life threatening disease. How could you be grateful? And it's because as horrible as chemotherapy and the surgery and the recovery is, you hear other people's stories and you're just like, listen, I don't suggest anyone get pancreatic cancer, but if you're going to get it, the kind that I have versus, stage 4, a Whipple, that's, half a day surgery, etc. And so, yeah, I mean, listen, you can look at certain things and say like, all right, the business, hasn't been churning the way it would have been if I was healthy, but that's life, right? You can always come back from that. You can't come back from not taking care of your health. So yeah, it's been quite a journey this last year.
Wow. Kyle, how long were you on chemo? Like, when did you start chemo? You had your surgery in July. When did you start chemo?
September. So it was 12, no, I'm lying. 12 treatments. So yeah, 24 weeks. 1 week on, 1 week off.
So you finished it like April, right?
No, February 18th.
Oh, February 18th. Okay, February. Okay. Ring a bell. Wow, 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 wow. But I hear you, I think that I'm so grateful for even having had cancer. And it's a crazy thing to think that, right? That we're grateful for having had cancer. But I think that it's given me my purpose, and we're making you have your purpose now, dude, because you're going to be doing this now for a long time. But also, it made me meet some of the best people I've ever known. I think my Blessed community is some of the best people I've ever known. So I'm so happy to have you in my family now, because you'll never go away now. So whatever.
Sir.
But yeah, I spent a lot of time with Dr. Fieke in Glasgow, and it was freezing cold in Glasgow. When were we there? In February? When was that?
Oh, yeah, February, and it was classical Glasgow weather with lots of rain. So
It was
sun is out
cold.
now, Ricky. But it's
Oh, cold rain.
we'll need to come back in summer.
I
But but yeah.
But she's like an amazing force in her craft. So talk about what you do. Talk about your patients and how you're saving lives.
Well, we're trying, but I think, Kyle, your story is instantly so typical, like just lower back pain. And I think that is the challenge we see when, we need to diagnose and then treat pancreatic cancer, where so many of my patients have gone and seen their primary healthcare physician and seen, oh, I have a bit of back pain, or I get this indigestion, and who in their late 40s, 50s, 60s doesn't have back pain at times, or it's on with a bit of indigestion. So they all get put on different medication. And then they only start to present to the hospital when patients become jaundiced or when they start losing weight and alarm bells start to go off. And most of the time it's then late and the cancer has already spread. And that's unfortunately what we see most of the time, and what my practice clinically also, most of the patients I see have stage 4 cancer. So, and then thankfully we have a few like Carl, where we catch it in time and we can operate. And also we have a few of my stage 4 patients who actually are doing very well on the cancer treatments. So I think those are the cases that we in some degree cling on to, because I think, yes, there are some groups of patients where we need to do better. But unfortunately, that's at the moment still the very minority. So yeah, what do we do, and what has made me so in some way so passionate in treating this cancer and improving the outcomes for pancreatic cancer is trying to understand, why do certain patients get more pancreatic cancer, and why do they get it at a younger age? And one of that is that we see, for example, in different patient populations. So, for example, we know that the patients of the African diaspora and the Black patient population gets more pancreatic cancer and earlier. Or in the UK, we also see it in patients from different regions within the UK. And why is that? And similarly, we see pancreatic cancer patients, they all have this 2-centimeter cancer. And one patient does really well, and the other patient gets really sick and starts losing it.
With the same size tumor, really?
Same size of tumor. And we start to understand some elements of it. So over the last few years, we've learned a lot about the genetic makeup of cancer. And some of this can be explained by looking at the genetic makeup, but there are also other things. And that's, so I call it patient factor. So I don't know, there's different, and we haven't quite.
Yeah, other like comorbidities.
Yeah, the comorbidities, but maybe we call it in science terms, we call it like the tumor and the host. And we study the tumor-host interactions. And what's the host? That basically is the patient. And we see all different factors. And it's one of the things we're studying within Sambai, for example, is how patients' environmental exposures and inflammatory or more infection signatures, how can they contribute to different cancer outcomes and behavior. So all those elements, and that's basically how, I don't know, how we try to bring together the treatment for the pancreatic cancer patients and then the research and do different clinical trials, because we do see novel drugs coming through. I do think the treatment for pancreatic cancer is changing. We see that 90.
Why do you think it's changing?
Yeah, so currently, and Carl has had hardcore chemotherapy. You asked about it, and Carl, it's not easy going. It's a combination of 3 different chemotherapies. It's strong, and many patients struggle to complete those 12 cycles after the operation, because it just is so much. You get all different side effects. But what we see, and it's currently in early trials, but I'm quite hopeful in that sense. We see that around 90% of pancreatic cancer have a change in a gene called KRAS. And
How do you spell that gene?
So it's a KRAS, KRAS. And it was always thought we couldn't drug that gene. But now they've started to make medicines, and we do see quite good outcomes, and it's well tolerated. So I think that's then there's lots of novel drugs coming through. So I am hopeful that we can also move towards better treatments that are better tolerated, and earlier detection. So it's a combination of things. I cover a
Yeah.
lot of different things. I don't know, it's from increased awareness, earlier detection. So we pick it up earlier, but then at the same time also better treatments.
Yeah. Well, the data I found and this is for US only, I couldn't find too much other country data. You know, the incidence rate for pancreatic cancer in Black people is 19% higher.
Yeah.
The mortality rate for Black people versus white people is 21% higher. In the US, right? Isn't that crazy? So, well, breast cancer, you know, we have a 41% higher mortality rate than white women. So, but still, I think that's across the board. But can you test for that KRAS gene? Should you get genetic testing? I mean,
so not routinely yet. And I think it's currently all done within a clinical trial.
and is the KRAS gene more prevalent in Black people? Do we know that yet, Fieke?
We don't. And I think, and there's, in terms of what is so different in Black people versus white people or other ethnicities, I think there's a lot more to learn. And in a sense, Ricky, I'm not surprised you found mostly data from the US, because that's where most of the studies have done, where there's lots of Black people globally. And I think we've also been missing out. So we see similar figures in the UK.
Right.
But at the same time, if you look at our clinical trials and if you look at our data where we look at the genetic makeup, it's still all from a very selective patient group. So we need to get much more diverse and learn a lot more about, well, even about statistics, because I think even the statistics we need to learn better. And then what's the different biology? Is there different KRAS genes? Is there different other genes or other?
We don't know about yet, right?
Probably.
Yeah. Wow.
Yeah.
Also, I'm looking at KRAS genes right now, and it looks like it's being studied for lung cancer.
Yeah. Yeah.
Right. So people with African Americans are significantly more likely to have the KRAS mutation in lung cancer compared to white patients, 37% versus 20%. So maybe those same numbers work. I mean, you know, if we're seeing it in lung cancer, could that also be prevalent in pancreatic cancer or other cancers? We don't know. I mean, I think that's maybe something we can find out with Sambai, right?
Yeah, exactly.
The work that we're doing. Wow. All right. So go back to the back pain, because at some point, like if I were watching this, I'd be like, my back hurts.
She also mentioned like jaundice.
Yeah, jaundice. But I mean, jaundice, you're metastatic. You're way down the pipe. You know?
Not always. Sorry, Ricky, for interrupting you, but sometimes, and you heard Kyle mentioning a Whipple. I think many people don't even know what a Whipple is, in a sense. So even if
let's talk about the Whipple.
So I think sometimes you have I sometimes compare the pancreas with Lake Garda. If you look at it, have a look on Google Maps, and if you see Lake Garda, that's how it kind of looks. But you have the head of the pancreas and you have the tail of the pancreas. And the head of the pancreas is really close to your bile ducts and your small bowel. And when do you become jaundice? If the cancer starts blocking.
What does jaundice mean?
Jaundice is also a good one. You look yellow. You get basically you start to look yellow.
Oh yeah, I know. Yeah, but I mean,
and it's obstruction of the drainage of your bile.
Okay.
Or your people sometimes with a big gallstone at times can also make you jaundice. So there's other things that can cause jaundice.
Okay.
But if you're jaundice and you don't have any pain at the same time, then it's also alarm bell. But sometimes it's still small, and then sometimes you can still operate. So jaundice is not always
not always
not always too late.
Okay.
But yeah. But that's the Whipple, that you take a bit of the small bowel out and the pancreas. And it's, as Carl said, it's a big operation. And if it's more in the other end of the pancreas, then the surgeons often can do things laparoscopically, and they take it's closer to the spleen, for example, the different
So if it's closer to your bowel, then you're gonna have to go take your intestine out, and it sounds all yucky to begin with, but you had laparoscopic, Kyle, so that wasn't too bad. You didn't have like a huge incision and all that stuff and recovery.
So Fieke, when we spoke yesterday, comparing things, I know a gentleman who had to have the Whipple, and my surgery is about 6 hours. His was like 16, right? Like I was in the hospital for 5 days. He was in the hospital for 2.5 weeks. I lost about 10 pounds during that period. He lost 40. He went from 180 to 140, right? So yeah, the Whipple it's no joke.
No. And even after, I think you get a lot more diarrhea at times. You need to have like your enzymes. There's all well, everyone needs the enzymes, but I think even after, sometimes it's difficult. Yeah.
This is difficult. Wow, so you're blessed not to have had to have that.
Yeah.
So let's talk about Sambai and kind of what you're doing now. Like what's your focus on Sambai? Because Kyle and I are Uza going to start to help recruit patients soon. We're working on all the communication materials for to get patients involved. And we want all of you guys to, if you're a cancer patient, to come be a part of this study, because we are going to change the world on cancer. So what are you doing? Like if you had me and Kyle's and Uza's blood today, a blood sample, what would you be doing right now?
I'm gonna say can I say one thing? Because just about the back pain, because I think the last thing we want is that people see this and they say, like you say, oh, actually, no, I've got a bit of back pain. We've been sitting on our desks all the time. We all have back pain. I think the most important thing is, and also I think, Kyle, what you all can take away from your story, if things don't feel right, go to your doctor. And I think if the pain doesn't go away, or you also start to lose weight for no good reasons, you're not on a diet, you're no longer hungry, go and see a doctor. Like if things are not right, in the end, back pain is common. Pancreatic cancer is relatively rare. But if things are not right, go and see your doctor. I think that these are the important things.
And back pain is so indicative of other things too, I mean.
Yeah, many things.
Even colon cancer, a lot of people complain of back pain with colon cancer. And so I think if you have back pain and it doesn't feel right, you need to go check it out. Just don't.
Exactly. I think that's the main.
Like Kyle's wife and say, hold on, honey, this does not seem right to me.
She advocated for you.
She advocated for you to get even a CT scan. That's also what we have to do when we do go to the ER. Okay, well, once you get to the ER, what are you going to do for me? How are you going to identify or diagnose me with the right diagnostic tools? And so asking for that CT scan, asking for that sonogram or ultrasound or whatever it's going to take, whatever body part we're talking about, but being able to say no enough to be dangerous, like your wife did, to say, hold on, wait a minute. How are you really looking at what's inside, what's going on inside? So I think that's really important, because I don't want everybody to say, oh my God, my back hurts, I'm going to the hospital. But
that's right.
Some point that pain is a sign of something.
Yeah, when something's off in your
body. Yeah, that pain's a sign of something, right?
Yeah, exactly. So, but and I think that's what we try to do with Sambai too, right? So then to go to I think a big part of Sambai, and Ricky, and that's what your fantastic team and Kyle, our Sambai warriors come in, is empowering the patient voice and raising the awareness. And I think overall we need to empower the patient so that they can come and go to the doctors and say, look, I've seen this study, I've seen this trial, can I do this, can I do that? And so I think that's a key element that we need to do for all cancers. And then in Sambai we study pancreas, breast and prostate cancer.
Yeah.
And hopefully we can build on it for other cancer types, because I think it's a general message.
Yeah, trial shouldn't be considered as a last resort. We want people to think proactively, and even before you're diagnosed, there are trials that have, trials outside of being diagnosed with something that you can be involved in, and they should be used as a tool from the beginning.
Yeah.
Hopefully we can.
Yeah.
help empower people to do that.
Yeah, and I think you know, that's what makes our communication of Sambai a little difficult, or not difficult, but challenging, because it's not a clinical trial. We're not going to give you something today that's going to help your cancer. We're going to make you part of a study that's going to help a generation from now, potentially, or maybe 10 years from now. We don't know. But I think what we're doing is pretty groundbreaking and iconic. And we're bringing a different perspective to cancer research that doesn't exist already, that could have impact for our communities, our grandchildren, our children, and our grandchildren. So I think that, you know, our challenge is to talk to patients and say, come join us in this research that could change how scientists think about cancer going forward.
Yeah. And I guess even when I introduced myself and spoke about my day-to-day job, I think the first thing I probably should have said that in the end, I'm also incredibly grateful to do what I do. Because in the end, what I find, patients and their families, everyone is so brave. And so if you actually sit down and speak with the people, talk about it, I think many people are very holistic and incredibly brave and willing to think about just what you say, Ricky. I don't do this for myself. I do this to improve the outcomes for this cancer. And I feel humble discussing it with it, because I think it is, but yeah, that's exactly it, that we think, oh, we want to learn it, and we can only find better treatments and improve cancer outcomes if we understand the cancer.
Understand the cancer better.
Yeah.
So we're hoping that, you know, we're starting to get more people in with watching our show. And we're so glad whoever's watching is watching our show today. From you know, Africa, from the African diaspora. Do we know anything? Can you speak anything about anything going on differently in Ghana, Nigeria, and South Africa, and the countries that we're studying in Sambai, Fieke? You know, I know like Zodwa is doing so much work in South Africa, and even you know, Dr. Clayton's in Nigeria. We have Dr. Beatrice in Ghana. Do we know of anything? Can we speak about that at all?
Yeah, I think, and I've got a colleague here from Malawi, and we had our visit to South Africa recently, and then indeed the team in Ghana and Nigeria. Pancreatic cancer it's in many of the countries, it's also still, people just die from it, to be honest. They not getting any treatment, not even a diagnosis at times. I think we speak about Africa is very different in a sense, all the different countries and all the different, I think there's differences even in South Africa. Some patients get fantastic treatment, and we have fantastic collaborators with the HPB group. There is an African, like the African European Pancreatic Cancer Coalition, and now what we are starting is what has started actually is the World Pancreatic Cancer Coalition, which is trying to bring together all the different pancreatic cancer.
The World Pancreatic Cancer Coalition.
And that is more from again, research and patient advocacy and charity point of view, where, for example, in the US, you've got Pancreatic Cancer Action Network, you've got Luscarda Foundation in the UK, we've got Pancreatic Cancer UK, Pancreatic Cancer Action. So there's a whole lot of different pancreatic cancer groups, and the World Pancreatic Cancer Coalition is trying to bring them all together. So I think that is one step. What we see, because to put it in perspective, even in the UK, we see that nearly 70% of patients are too sick to receive any treatment. So they come and see us.
They even receive treatment. They're too sick. 70% in the UK are too sick to. So by the time they get to you, you can't even treat them.
Yeah.
Is that what you're saying?
Yeah. Or they come and see us, and some days they come and see the surgeons, and then they see me in the oncology clinic, and they are just they're too sick and too unwell, and they just so that's 7 out of 10 people. That's a lot of people, and it's incredibly difficult.
Look at God, look at you, Kyle. Look at God.
Yeah, so I think that's why I will need to have and it's, I think it of course it depends a little bit where you are also, and I don't quite want to speak about Africa because I don't really work there as a clinician, but also there, just speaking with the people there, sometimes it's just difficult. And when patients are too sick, you're not
Yeah.
going to do a big biopsy or a big operation. You make sure that their pain is controlled and they die with the peace and dignity rather than all different invasive procedures. So that's what we see also in the UK, that sometimes people don't even get a biopsy to get what we call a tissue diagnosis, because we feel it will need to be focusing on their symptoms rather than anything else. So I think that's a big it's a big unmet need in that sense.
Well, yeah, the stories you hear, like my mom's hairdresser. She was 59. She did my mom's hair on June 15th and she was dead on July 4th.
Yeah. And it's awful. It's awful for the patients and the people who stay behind, because it's just, you have no time to come to grips with it. And I think that's, you see now there's an increasing need. We're starting a trial against cancer cachexia, for example. So cachexia is if you lose a lot of weight and you become very, you're not hungry, you don't eat. So yeah, there's a big need for us and to raise awareness, but then also to make the symptoms better and to make the pain better, so we can get more patients to treatment.
Yeah.
That's, sorry, I keep going.
Keep going, keep talking. The World Pancreatic Coalition looks great. It looks like there's 100 different global members. We'll reach out to them. Reach out to them and see like if we can tap into those networks and see. Yeah, we haven't really found too much focus on Black and African patients, so but we'll try to be that voice on some of this work, because we're seeing that we have higher incidence in mortality.
And I think one thoughts we have, and it's something we try to work on, even a study where we start to look at giving enzyme replacements to people in Africa more, to see at least then you improve the quality of life and sometimes also even the survival a bit. So I think there's different things.
Can you explain that a little bit?
Yeah. So do people know what a pancreas does? Even that, some people actually, when we asked about, they don't even know what a pancreas does.
That's true.
In normal life. So a pancreas has, broadly speaking, two functions. One of it is controlling all the sugar levels, so making insulin and all the hormones needed for your glucose levels. But the main function also is making all the enzymes that you need to digest your food. And that's actually a key function.
Break it down.
And when we speak about pancreatic cancer, we mostly speak about cancer that affects the function of the pancreas that makes all your enzymes to digest your food. So if you have a pancreatic cancer, you don't make enough of those enzymes. So you're
digest your food.
Yeah, and what does happen? You start to feel bloated, you get diarrhea, you start losing weight because everything you eat
those are also symptoms too, then, if you're starting to get
Yeah.
So interesting. So can you speak to a connection between pancreatic cancer and diabetes? Is there a connection there if you have diabetes?
So now on the symptoms, a lot of research is going on in this area, because again, diabetes is common, pancreatic cancer is relatively rare. So it's not for all diabetics to think, oh, I may have pancreatic cancer because now I have diabetes. But if you've had diabetes for years and suddenly you see that the same dose of insulin is no longer controlling your sugar levels, then you may think, oh, there's something happening. Or if you start to have other symptoms like, yeah, persistent weight loss, or you can't control your insulin, or you don't quite, yeah, behave like a traditional new diagnosis of diabetes, and you get diabetes all out of the blue, where you don't have any other risk factors for diabetes, again, then I think that could be a warning sign. And
Right.
people will be doing a study in the UK actually to really say, do we need to look at new onset diabetes as an early symptom for pancreatic cancer? It definitely is not for all new onset diabetes, and we need to fine tune it a bit.
How
Um,
many of your patients would you say have had diabetes with their cancer?
Quite a lot. But also our chemotherapies at times give diabetes, because we give a lot of steroids with our chemotherapy, and they can cause diabetes. But I would say 70%, roughly speaking, has diabetes. Yeah.
Wow, wow,
Yeah.
wow.
Wow.
So if you have diabetes, and should you get tested for the CRAS gene?
Okay, was it? At the moment, not yet. We're not quite there yet, I think. Because also then, but maybe that's where we're heading in the future. There's lots of research in the early detection of pancreatic cancer, and one of them is looking in the blood to see, can we pick up changes in the DNA. So
DNA, yeah.
in the
So
gene.
if I have diabetes and I get a back pain, I mean, I don't know, right?
No, and early detection of pancreatic cancer is a massive topic.
We'll look at
And-
Kyle. He didn't even have to have the Whipple because he
Yeah.
early detected it, right? But still, he was stage 2.5 or whatever, 2.5, even though it was early for him. You know,
Yeah.
what would have happened if you had gone to the doctor on that first back pain you had in February, right? Before May.
And my tumor was aggressive. It grew 50% from when they measured it with the endoscopy to when they took it out like 5 weeks later during the
Wow.
surgery.
Yeah.
Yeah.
That's like my tumor. I had the same thing with triple negative. The month between my diagnosis date and my surgery, my tumor grew significantly. Yeah.
Yeah.
Wow. Well, all right. So lots to think about. Lots to think about.
Lots of work to do.
Yeah, lots of work to do. If you think about how can we encourage people, but also to me, I want everybody just to be a little scared of their health. You know, I don't want you to be like overwhelmingly scared, but I mean, and not maybe scared, but diligent, right?
Don't miss your appointments.
Don't miss your appointments. Don't miss your checkups. You know, I had, my doctor found my triple negative breast cancer on an annual checkup. Had I been doing self exams, I probably would have found it way earlier, or like, and like Kyle had this situation where, he was just going to kind of suffer through it. And his wife said, nope, we're going to check this out. So just being diligent about your health is so important. And then if you want to be a part of this research, we are here. We're going to be all over the world now, trying to get some samples and get people engaged and do this work. So any other words of wisdom you can share?
Yeah, no, anything, yeah, anyone, please get involved indeed. And it's all, I think, one always an important element, I think, also for research is, because what Sambai, we trying to really understand the differences, what's causing Black people to get more pancreatic cancer. But all the research you do, only your own doctor will know who you are. We as the researchers will not know
Right.
or not know any details. So I think just from like confidentiality aspect or anything, because we do all those things, but it's all very well regulated. I think that also is an important element to say your
Yeah.
sorry.
Yeah, your health information will be protected and you'll
Yeah.
help some people, help the world.
Yeah.
Kyle, any last words?
Just, listen to your body, and it could be annoying. We get caught up in work and life and, oh, I don't have time to go to the doctor and see. But again, if I had just thugged out this time like I did the first time and kept going, then it's a different situation, right? And so absolutely listen. It's better to be safe than sorry, for sure.
Yeah.
Great, great. Well, this is Sambai Speaks. Thanks for being with us
Thanks
today.
so much.
Liz and I will be with you in a month. We'll do another episode. Thanks, thanks for being here. Thanks for teaching us about something that I don't think a lot of people know about because it happened so quickly. People are gone. So we're going to do our best to change those odds, right? Thank you.
Thank you. Thanks, Ricky. Thanks.
Thank you.